thank you, Gauri, for all your kind words, Dr. Karthik, Dr. Abulasan. On behalf of the state office, Abulasan sir, Dr. Abulasan, Dr. Gauri Shankar, Dr. Karthik Prabhu, Sengutan Sridhar, I request all the participants to become not only members of IMA, if you are not already member, become member of the scheme also. In another 15 days, Dr. Abulasan will be handing over. Before that, we request at least a few members to join the schemes. It would be very nice if you could please make it. Aruljothi, please send a message to all of the members who are, if not they are members of IMA, ask them to join and also in the schemes. Okay, yes. Dr. Aruljothi, please do it. And if Sengutan is not there on the line, I think we can proceed. Sengutan?
Yes. Sir, sir is not able to join, sir. We will
we have a wonderful moderator, my very close friend, a very nice person in Dr. Very ethical practice, Dr. Srinivas. He is a wonderful clinician. He is in FRCP Glasg also. He is one of the best clinicians we have in Trichy now. Dr. Srinivas will moderate, and we have our Dr. Subramanian, who is a very active member, not only in IMA, Tirunelveli plus state IMA, and also in Association Officials of India and Rheumatology. He is also an examiner along with me in MRCP. I request the proceedings to start, please. Thank you, Aruljothi. Please start the session. We have already got one. Yeah.
Sir, thank you, sir. Thanks for introducing moderator, sir. Now I request moderator to introduce the speaker and start the session, sir.
Ninga, if you have got anything about the moderator, please do it, Aruljothi, please.
Yes, sir. 1 minute, sir.
Please, please.
1 minute, sir.
My just
Yes, sir. We are happy to have Dr. S. Srinivasan, sir, as our moderator. He's a senior consultant practicing in Srinivas Hospital in Trichy. He did his MBBS from prestigious Tanjavur Medical College, followed by his post-graduation from the Coimbatore Medical College. He is having a lot of awards, papers and publication to his credit. With this introduction, I am giving the session to you, sir. Please, sir. Please proceed the session. Thank you, sir. Thank you very much, sir. In the event short message, even before starting the event, we collected the questions and comments related with the event, and I submitted these details to moderator. We will have good discussion at the end. Please do join the meeting till the end so that we can have good discussion. Thank you. Thank you, sir. Yes. Subramanian, sir?
Yes, sir. Dr. Srinivas will introduce.
Sir, Srinivasan, sir.
Yes. Good evening, everybody, sir. I immensely thank the IMA, especially the president, the most respected president of IMA, and especially my guru, Dr. Ashraf, sir, who is a chairman of academic committee, and Dr. Aruljothi, convener of IMA state branch, for giving me this special opportunity to chair the session on this very common and day-to-day topic of rheumatological diseases in primary care. Actually, this is actually 1 out of 10 patients who come to us to the OP. Mostly they have some rheumatological complaints, but whether it is really organic rheumatological problem or secondary to some other thing, we have to differentiate. And none other than Professor Dr. N. Subramanian will be enlightening us on this important topic. And there is a great expansion of knowledge and understanding of these rheumatological diseases of late, as all of us know, and especially in the diagnosis, investigation, and treatment. There has become a battery of investigations, right from a ESR to very complicated investigations nowadays. So it is one of the field which is rapidly expanding, and it has got a lot of scope. And whenever we were 10, 15 years back in our 2-tier cities like us, we didn't have any rheumatologists full-time. Actually, they used to come from Chennai or somewhere near big cities, and that was the state of affairs. Now we have a handful of them, which is a great help to our patients who are in great need of this treatment. So I'd like to introduce Dr. Professor Subramanian, who's an MRCP, MD MRCP UK, and MRCP Rheumatology, and he's got a FRCP from Edinburgh also. He's now a consultant rheumatologist, Tirunelveli, and he's a professor of medicine, assistant professor of medicine and rheumatology at Velammal Medical College, Madurai. So his special interests are in rheumatoid arthritis, SLE, spondyloarthritis, and about biologicals and biosimilars. And he's got a lot of publications to his academic credit, around 25 of them in very indexed journals, and he's delivered a lot of guest lectures in international and national conferences. He's about to deliver a lecture on 25 APCON also, I think. It is no doubt it is there. And he's an assistant editor and referee of JAPI, Indian Journal of Rheumatology, and so many other journals. He is awarded Aruljothi Award from the national. It's a national award of meritorious services, Best Citizens Award, and Best Secretary of IMA Award from Tirunelveli 2020. And he's got an academic award from APA 2021 and Doctors Day Academic Award from 22. And icing on his cap is a Distinguished Teacher Award by Tamil Nadu State IMA in 2022. And of course, he's a life member of so many associations, including API, IMA, and British Society of Rheumatology, and so on. Actually, this was a very short introduction because he's got so many other things to his credit also. And now I request Professor N. Subramanian to deliver his talk on the topic rheumatological diseases in primary care. Over to you, sir.
Good evening, sir. Thank you for the kind introduction, and really thankful to the IMA State Office Bearers, Dr. Abdul sir, Dr. Karthik Prabhu, Dr. Ashraf sir, and also Dr. Srinivas sir, and the academic committee for giving me this opportunity. It's really a wonderful little gesture. The whole year we've been given a one-day session. So I did my UG internally, and I can't forget our teachers, Prof. Edwin sir, and also Dr. Paul Emery from UK. So I trained in Leeds. So rheumatological diseases are all multi-system disease with the immune background. So it is a disease of mimics sometimes. So as our moderator was saying, we have rare diseases, we have complicated diseases, and we have lots of investigations also. So we have multiple cytokines involved in the pathogenesis of disease. So I thought I'll give you a brief overview of different diseases, what we deal with, and also give you some examples to get to easy diagnosis. So that's my main outline. So we'll have different clinical features. We'll come to the diagnosis, therapeutics, and some amount of research if we have time with it. So worldwide, people are living longer nowadays, and we all will get, as our moderator was saying, we'll have at least 1 in 5 people will have some joint involvement. It may be osteoarthritis, it may be age-related changes, but rheumatoid is on the top with 18 million people worldwide, but that was a few years ago. And it's predominantly immune system disease, women space. So except ankylosing spondylitis, all are women-dominant disease. I'll tell you why it is. And they also experience different level of disability. So unless we catch them early, it's very difficult to get them back to work or look after the family. Autoimmune diseases affect 1 in 10 people, and this was in Lancet. So the reasons being high estrogen in pregnancy and also in women people, and also androgens have inflammatory and anti-inflammatory effect. So it's both either immune-mediated cell disease or antibody-mediated disease. So all of them trigger the autoimmunity cascade, resulting in cytokines. That's why we get multiple symptoms and different scenarios. So at the outset, we need to differentiate whether it's inflammatory or non-inflammatory. The reason being, inflammatory disease are very well controllable, and we have lots of interventions to do it. Non-inflammatory is usually a short disease, short term. So their symptoms are very much short term. So they worsen with activity and improves with rest, and stiffness is very mild, and inflammatory markers are normal. Whereas in inflammatory disease, you get early morning stiffness, better with activity and worse at rest, and high CRP, and you get also synovial effusion with joint involvement. So this is a teaching slide for people who had rheumatoid arthritis, but we would not like to see these things because we have early intervention. So anybody who has, like young women who have currently upper limb joint involvement, more wrist and MCP joint involvement with the symptoms of early morning stiffness, think about rheumatoid. So this is deformity, and this is eye disease, and this is skin disease with vasculitis, and then you have renal involvement with amyloidosis, and also lung disease with interstitial lung disease. So these are all systemic complications, but they may not manifest straight away with these, but they may come to you or come to us with painful joints. So we need to also, our history is usually head to foot. So தலையில முடி இருந்து முடி கொட்டுதா அதுல இருந்து ஆரம்பிச்சு until the feet will normally ask all questions, and these are all some unique skin lesions which will be useful for diagnosis, especially psoriatic plaques. So the psoriasis normally in the hairline, in behind the earlobe, and also in around the umbilicus and in the knee joint and back of the elbow. These are the areas which are hidden. So keratoderma planoregicum is usually in the soles and the palms, and butterfly rash usually around the malar area, and juvenile arthritis you get salmon colored rash, rheumatic fever which is very much less common nowadays, erythema marginatum, and also painful nodules in the shin of the legs. So you get in sarcoid or empathic arthritis. So the moment you get these symptoms, we have to think these diagnosis, and this is more of a TOFI patients. This is more common in the primary care, really. Osteoarthritis with the crystal arthritis in the knee joint and also the wrist, elbow. So you get MTP joint involvement and knee effusion. So this is more common with the people, renal disease, diuretics, heart failure, and also lots of alcohol and also non-vegetarian food with high uric acid content. So high uric acid is a risk factor for cardiovascular disease too, but at least we should be able to limit it with the improved awareness. So gouty arthritis, why it is common in MTB? Because it has more activity and more degeneration. So you get high uric acid crystal deposition. And this is important to remember, when there is acute gout, it may not be in the serum. So all of them have gone into the joint, so causing inflammation. So you may not be having a high uric acid in the serum, but it may be normal initially, but eventually it will get worse. So, and the patients normally respond to anti-inflammatories or steroids for a short term before we add any uric acid drugs, which usually after 2 weeks, not at the straight away. So this is patients with skin psoriasis. You have hidden areas of psoriasis and also nail involvement, very much explained there. So nail pitting, DIP joint involvement, and also knee and the tendon involvement. Tendon involvement is more like a flexor tenosynovitis or trigger finger or trigger thumb, and also shoulder, elbow. So usually tenosynovitis is more common with the psoriatic groups. The major difference is the DIP will be involved in these groups, whereas rheumatoid, you don't get DIP involvement. And that is rheumatoid factor positive, this is rheumatoid factor negative. So that will help you delineate that. So psoriatic arthritis are increasingly being recognized across Indian subcontinent. And there are 5 different types of psoriatic arthritis. So one is more DIP joint involvement. The other one is like ankylosing spondylitis, which is the inflammatory back pain. So anybody young population, back pain, which is worse at night time, think about inflammatory back pain. So that is early angspond or ankylosing spondylitis, and enthesitis and dactylitis, which is very specific feature of psoriasis. A number of occasions in a patient with diabetes, they have these dactylitis, but being treated as osteomyelitis, but then come to us and then we look at the scalp where it is hidden, it is psoriasis. And arthritis mutilans is deformity, which we don't like to see, less common. So we need to diagnose early, because you can see by the time 50% of patients come to you, it has already started erosions, and nearly 5 years down the line, you get 50% develop deformities. So unless we catch them early and treat them early, it's going to be a problem with cardiovascular mortality too. And any systemic disease, you also get atherosclerosis, hypertension, and diabetes, and also high CVD risk. And you can see metabolic syndrome is also coming up with that. So compared to the general population, inflammatory disease has a 1.8-fold risk of cardiovascular disease. And it's not only the joint disease, it has lots of influence in the family itself, like emotional, financial, social. And because it's very obvious in the skin, it's limiting their social activity, and leisure activities also will become less. So this is a MRI scan of a young chap who had inflammatory back pain, which I say inflammatory is back pain in young population, worse at night, better at activity, and responding to simple anti-inflammatories. So you can see it's a MRI showing a bone marrow edema and erosions in the sacroiliac joint bilaterally. This is suggestive of ankylosing spondylitis, which is a part of the psoriatic arthritis group. As I said, in a negative group, these are the 5 different spectrum of diseases in psoriatic arthritis group. So one is the HLA-B27 genetic link. The other one is the colitis with the bacterial link. And then you have shared epitope. And then you have chemotactic factors. So apart from psoriasis, you can have spondylitis, you have peripheral joint involvement, you have tendon involvement, and colitis and uveitis. So uveitis is part of this seronegative group, where so patients may have eye involvement first. So many occasions we do get referrals from the ophthalmologist or from the bowel disease that they may have spondyloarthritis. And if you look at them, there will be 30% of them will have psoriasis. So this group. So how to suspect spondyloarthritis, inflammatory back pain in the young, and a good relief with the anti-inflammatories, usually referred pain to the buttocks, which is a specific feature from sacroiliac joint. So, and usually it's bilateral. So when you do MRI, patients may have unilateral symptoms. Unilateral symptoms, and if the MRI is unilateral, think about TB, which is a close differential. We shouldn't miss that, especially in endemic country like this. And B27 is positive in only 10% of the population. And those who have ankylospondylitis, you have 30% B27 positivity. This is anterior uveitis hypopaean, and also with unilateral keratitis, and also keratic precipitase in uveitis. So these are all from ophthalmologist. So we also form part of the APLAR, which is the Asia Pacific group of looking into the research and registry for spondyloarthritis, where Madurai Velammal is one part of that, where I'm working also. So as I said, it is the spectrum of diseases, all 5 of them together. It's a unified concept. So if you get one of them, please try to link to us where we can pick up the diagnosis and intervene early. So that is the more arthritis group. Now we're coming to the connective tissue group. So there are 3 different groups, major inflammatory diseases we deal with. One is the arthritis, the other one is connective tissue disease, and the third one is vasculitis. So this is the second group. Patient நான் சொல்றது அது வாதம் மூட்டு பாதிக்கும். இது உள்ளுறுப்பு வாதம்னு சொல்றோம். இன்னொன்று ரத்த குழாயில உள்ள வாதம், இரத்த நாளங்கள். So அதுதான் major 3 groups. So of these, lupus is more common. Next common will be the scleroderma. Third one is myositis, dermatomyositis, and also Sjogren's. The other things are less common. So this is a teaching slide for PGs and students. So you can now use some SOAP Brain MD for diagnosis of lupus symptomatology. So you see, so these are the diagnostic criteria for medical. When I was a medical student, normally people who have head to foot symptoms, as I said, fever, weight loss, malar rash, Raynaud's phenomenon, and also oral ulcers, and then painful joints. And then if you look at the blood parameters, you get anemia, thrombocytopenia, and also leukopenia, and protein leak, and also immunological antibodies. And you can also have pleurisy, pleural effusion with breathlessness also. So these are all different systems. This is many of you are aware that it can affect any system. So anybody who has fever, weight loss, and a skin disease, think about rheumatological diseases, which is lupus. So this is predominantly pregnancy related. So there is something called APLA syndrome, where you have antibodies causing miscarriages, and it may mimic as HELLP, which is more common with pregnancy, hemolysis, elevated liver enzymes, and also thrombocytopenia, and both can mimic as DSAC, which is a disseminated intravascular coagulation. So it is a very close DD, but it's an emergency diagnosis when you are handling predominantly pregnant patients. So at this point, the practice symptoms are in a fever, low counts in a woman, think about lupus. And anybody who had ITP, which is like a purpura and also menorrhagia, so think about background ANA positivity. And anybody who has hypothyroid and Raynaud's, think about ANA. And these are all like a precursors of lupus. So if we find them, we can advise them, and also try and limit any systemic organ involvement. There are some patients who have only skin disease and ITP. That's it. No other complications. So weight loss, as I said before, if you have lymphadenopathy is also part of it. So close differential is tuberculosis. The professor used to say that if you have 3 systems involved, any patient with the complaints, think about rheumatological diseases, and you get overlap also. So this is male lupus, which we have presented in 2016 in Venice. So male lupus is also increasingly common. So they are more neurodominant diseases. So if you look at the ANAs, this is a study from many years ago, back in 2003, actually published in NEGM. So you get at least 10 years before the diagnosis, you can pick up positive ANA and these Raynaud's and Kikuchi disease, and also ITP. So it's important to figure out and try and get the preliminary diagnosis. Whether we can prevent or not, that's different question, but at least we can make them aware and avoid complications. This is the ANA profile for any patient with a suspected lupus. We do that, or any connective disease, we do that. And it will be a control, and all others will be abnormal reports. So based on these, we can assess which system can be involved. So different antibodies have different diagnosis and have different predilection towards multi-system disease. So as I said, AMPLA syndrome is recurrent venous thrombosis, arterial thrombosis, and it's a young stroke, myocardial infarction. And post COVID, we had lots of people with the thrombosis, and some of them we have also identified they have AMPLA hidden. So they didn't have thrombosis so far, but the AMPLA antibody presumably also is a trigger for developing thrombosis. So for criteria diagnosis, you have at least 2 episodes of thrombosis or 2 episodes of antibodies, and then you have 1 thrombosis. Miscarriage is also considered, especially second trimester miscarriage is considered as intrauterine or placental intraplacental circulation thrombus. So that is also included as part of AMPLA syndrome. So there are a couple of my own patients. So you can, so this is a patient with a 24-year-old developed lupus after 7 months of wedding. So predominantly MSK, which is musculoskeletal disease. There was mild proteinuria. She was very well with azathioprine and hydroxychloroquine. So 1 year after, she wanted to conceive. So we have given rituximab, which is the infusion given for patients with inflammatory diseases. And 6 months later, her immunology became negative, then pregnant. And she delivered a very good baby, and she is in remission. She is drug-free remission, no disease, no drug, and that's what she is. And the Velammal team has been very supportive. So she also had a mild renal disease, which all in remission still now. And recently, this is a recent one, again, Velammal patient. So lupus AMPLA. So during her previous pregnancy, she was found to have intracardiac thrombus at the 6th month. So we have to abort and then proceed for surgery. After the cardiac surgery, we thought it could be a myxoma. So once it is removed, it is not myxoma, it is predominantly thrombus. After that, she had become pregnant. So there was a lot of issues with the divers and all the things, but we convinced them. And she now delivered live baby without any complications all along. See, this is 4 months ago. So lupus and RA can have similar symptoms. It's difficult sometimes for us to differentiate, but this is more of a joint disease, that is more of an internal organ disease. So that is very much, and also photosensitivity and significant weight loss and hair loss, which is very differentiating compared to the rheumatoid group. So there's another patient. So there is 34-year-old leg edema after a fall. She had a native treatment, but she became breathless and she had pulmonary hypertension. And with that, because of the leg edema, she was having a Doppler which showed a femoral vein occlusion, which is again, like AMPLA, and she also had pulmonary embolism. So she had all the inflammatory immunological evaluation negative. She had femoral-popliteal DVT, and that's it is. Because of her high pulmonary pressure, she had, so this is, she checked for AMPLA, so all of them positivity. She also had now pulmonary thrombectomy from Shankara Nethralaya Hospital in Bangalore, and now she is symptom free. Her pulmonary pressure has come down from 80 to 36, and she's just on 1 anticoagulation drug, and she's oxygen free. So this is livedo reticularis, this is malar rash, this is Moy malar rash, this is subcutaneous subacute lupus, and these are all patients with cutaneous lupus. This is You can see very well, it's a scleroderma face. So pinch nose and expressionless face, and also microstomia. So this is more classical of scleroderma, which usually affects the skin vasculopathy. So you get Raynaud's and also interstitial lung disease, and sometimes you get pulmonary hypertension. All of them manifest with breathlessness. This is calcinosis cutis. This is interstitial lung disease. So that is one group of connective tissue diseases, which is more like lupus and scleroderma. And patients with the Sjogren's is usually painful joints and dry eyes, dry mouth, which is quite common for open mouth breathing also. So we tend to do a blotting paper analysis for wet or dry eyes. And also we get dentist review before we get the diagnosis of Sjogren's. So this is the third group, which is the vasculitis group. So these are also any rheumatological disease, as you know, it's a systemic disease. You can get thrombus or bleeding predominantly. The patients usually manifest with sick, these things in these patients. So they become very moribund within a few days with a fever, weight loss, and a bleeding, and also purpura and nosebleeds, and also hemoptysis, hematochezia. So three major groups of systemic vasculitis. One is the large vessel, which is like a Takayasu, and also giant cell arteritis, which is more upper limb and a cranial vessel involvement. And you can get abdominal aortic involvement too. So anybody who has a variable blood pressure or absent pulse in one limb, predominantly left subclavian, left radial, think about vasculitis. And medium vessel is predominantly like a skin disease, and also digital gangrene and abdominal pain, celiac vessel involvement, or if it is a small vessel disease, which is more predominantly ANCA associated, which is a biomarker for a small vessel disease, and you get renal disease, skin disease, and also lung disease. This is different forms of cutaneous vasculitis, and this is HSP. And the other two are cryoglobulinic vasculitis, and third one is urticarial vasculitis. ANCA, as I said, anti-neutrophilic cytoplasmic antibody. So there are two different types, which you don't have to worry about it, but we check both of them together, ANCA EMPO and ANCA PR3, or a C and a P ANCA. So check both of them. One of them is lung dominant, the other one is kidney dominant. This is angiogram with the Takayasu vasculitis. You get renal disease, you get celiac disease, and also aortic arch, cerebral vessels, and also left subclavian. This is MR angiogram of aorta, which again shows, you can see narrowing of the vessels here. And you get also ocular involvement with scleritis, retinal vasculitis, and also iritis. This is a CT showing renal and also both renal and also celiac axis stenosis and intracranial aneurysms. So although this is an image from HIV, but you also get a similar picture from cerebral aneurysms and also vasculitis. And if it's a primary CNS vasculitis, it can affect the spinal cord or cerebrum also. So rheumatic disease are predominantly OP patients, but we are not immune to the intensive care because the reasons mentioned there. And the most common reasons are either they get bleeding and lung disease, or cardiorespiratory disease, or vascular ischemia. So this is about the disease manifestations, or it may be due to the drugs, which also if you get infected, then you get suppression of myelosuppression and also infection secondary to these drugs. Or it may be due to adverse effects of disease-modifying drugs. As I said, methotrexate is once weekly, but if somebody takes every day for 3 days, then they become cytopenic, mouth ulcers and glossitis and mucositis, and they have to be ICU admitted. So, predominantly affecting young females, multi-system disease, and potentially multi-organ failure, because it's affecting every system and it's quick and it's immunocompromised post. So the vaccination is being discussed in many settings for these patients. Metabolic syndrome I have alluded to earlier on. So apart from cardiology, this is the one where you have every other system involved. So vascular disease, one, here it's multi-system disease. And I'm not enumerating all of them, but endothelial dysfunction, and also insulin resistance is part of the metabolic syndrome, which is also happening in our rheumatology diseases. So, and if you look at only the cardiovascular manifestations, you can affect anywhere. Myocardial, pericardial, vascular are also current electrical and valvular disease. Lupus endocarditis is, telltale sign of lupus endocarditis. So, although it's a multi-system disease, we always have discussion with every specialist which is needed, and primary care provider is a major of them, and the pain is also part of our team. So this is another publication from us a couple of years ago, cardiopulmonary disease and lupus. It is changing. Initially, it was predominantly pleural effusion, pericardial effusion, but nowadays you have more myocardial involvement, also endocardial involvement. So these are, in a nutshell, these are all drugs for rheumatoid, but the number of drugs, I think the drugs itself take another day. So anybody who comes with inflammatory joint symptoms and we diagnose either with the clinical, apart from CRP and anti-CCP, which is the more specific antibody for rheumatoid arthritis. So you diagnose it, and then usually they get anti-inflammatories, both steroid and non-steroidal, but do not give more than 3 months. Before that, we need to move on to specific DMARDs like methotrexate, sulfasalazine, leflunomide, hydroxychloroquine. These are all conventional, but they don't work straight away. They take at least 6 to 8 weeks to work. So until 3 months, we need to keep them on steroids and anti-inflammatories. But after that, it's better to stop or consider switching over. And if they do not respond to the conventional, then you have biologic DMARDs, both oral and also parenteral. So you get TNF inhibitors, you have IL-1, IL-6, CD20, CD19, and also interleukin-17 inhibitors. So specific diseases, specific cytokines are involved, and the specific drug blockers. So that is a key. And JAK inhibitors is a new drug in the pipeline. It's been used for the last 4 or 5 years. So they are oral biologics. So since 1930s, when steroids were found to be helpful, and you have a number of drugs you can see which will tell us the history. So biologics, what are biologics? They are protein drugs. They are prepared from recombinant DNA technology and lesser side effects compared to the traditional immune modification drugs. And they finish with the MAB or SEPT, which is based on the monoclonal antibodies from which they have come from. And these are number of biologics listed there based on their cytokine blocks. I'm not going to go into that, but we need to choose the right drug for the right patient at the right time. That is the key. I thought we'll share with you common side effects with the specific drugs. Hydroxychloroquine is a safe drug. But only thing is it can cause pigmented retinopathy, and do not use more than 1 tablet a day, which is 6 milligram per kilogram. Sulfasalazine, it can cause colored urine, so that has to be warned, and the sperm count can go low with this drug. So beware for giving male patients. Leflunomide, we do not give until they become menopause. The reason being, it can be there in the system for 2 years, even if we stop it today. So, and monitoring is hypertension. It can cause hypertension, it can cause weight gain, and also liver function derangements. So they need to be monitored. Methotrexate, explained there. Cyclosporine, we do not use them anymore unless we have renal disease or skin psoriasis. And the tacrolimus, mycophenolate, they are all drugs for lupus, similar to azathioprine. So side effects with the biologics, so you get opportunistic infections, you can get TB reactivation, you can get injection site reactions, inflammatory bowel disease only with selective drugs, not all drugs, and you can get infusion reactions, cardiac events, very less common. There is something called biosimilars, which is more Eastern Asian countries tend to use that. So steroids. So this has been used for many centuries now, at least nearly 70 years. It is very good anti-inflammatory drug, and it can be used as a bridge between the specific therapy, but it is not without side effects. Many people have diabetes, hypertension, the skin become very thin and they get ecchymosis, and also osteoporotic fractures, which is really concerning. So this is one of my patients who had vertebral fractures due to steroids, So because their innate cortisol is suppressed, so you can't stop them. So they will have to be on ever lifelong. So, and AVN, which is avascular necrosis of hip, is another concern with the steroids. So lots of risk factors. So generally avoid that. And osteoporosis is one another metabolic condition for all of us. If you are going to live more than 60 years, we will have osteoporosis. So it's increasing. It's not only female, it's also in male. And especially Indian studies show more male involvement compared to the Western studies. So burden is going to increase. This is pediatric rheumatic diseases. I'll skip that for the time being, but they also get similar inflammatory diseases. The median age observed is 8 years. So 63 females and 52 males. So in children, they emerge, and multisystem disease, predominantly hematological, and also CNS involvement. So juvenile arthritis, IPP, autoimmune thyroiditis, and also Kawasaki disease, which is young people with myocardial infarction. And so what's new? So genes are involved. Genetic biomarkers are getting picked up, although a lot of research is going on. So I'm not going to go into the details of it, but HLA-DR4 is one specific gene that stands out for patients with rheumatoid arthritis. But diet, many people ask about it. Yes. So generally, Indian diets are very good, and reduced protein intake is better because protein can cause, especially meat, can trigger the inflammatory process, and fried foods, sugars, alcohol, all have to be avoided. So telemedicine is coming up in rheumatology after the COVID-19. So there is patients also feel better sometimes with the remote consultation, partly because they are not able to mobile very much and come to the consultation. And artificial intelligence also is being employed in getting the laboratory data. ChatGPT is being considered as a specific tool. Let's see what's the space, how it is implicated. We have been publishing different data. This is one in Rheumatology Journal from British Society of Rheumatology. And ultrasound is another tool to find out about inflammatory disease early on. If you're not sure, patients have painful joints, we can consider MSK ultrasound. There are some specific centers in every city they have a dedicated MSK ultrasound. So that can pick up tendinitis or even like a fire inside the joint. So patients are also happy that they have seen the diagnosis. And MRI, if it is not beneficial with the ultrasound, or especially in the spine, you can do MRI. This is MRI of the digits, which shows inflammation, especially with the psoriatic arthritis. And this is CT that again gives the erosions. Mainly, we can pick up in the CT. ANA is one biomarker for patients with suspected lupus, and this is the ANA profile. So you don't have to go into that, but each antibody specifies each diagnosis, and also it may give you the clue about which systems can be involved in those. So ANA profile, there are different patterns like peripheral diffuse speckle pattern. Until I complete MD and become a rheumatologist, this is very tough to remember. But it is easy to read and learn, but once you are facing the exam question, it may be tough. So this is again the profile report. So one word about rheumatic heart disease, which when we are in medical college, we were seeing lots of patients. Nowadays it has come down, as you can see, from 1992 to 2007, it is coming down. Prevalence and across the India, and this is a ICMR study. And the prevalence recently is less common. So anybody who has younger patients with painful joints, you can think about rheumatic, but it's less common. So and having ASO positivity doesn't confer the diagnosis. So on many occasions it can be like reactive to some infection in the skin, dental infections, genital infections, urinary infection. So any streptococcal infection you can get. So beware that it is not rheumatic, because otherwise they will be on penicillin forever. So this was cardiovascular disease. So just to highlight that CVD is also major morbidity and mortality in patients with our own inflammatory disease. So future definitely will change a lot of our practice. You can see For diagnosis, people are using biosensors and robots for treatment and logistics, and also patient support using the artificial intelligence. And stem cell transplant is being performed in some centers abroad, especially with the Sjogren's and also scleroderma. And digital world. So we have analyzed about artificial intelligence among medical students. Still a lot to know about AI. Just 3 more slides, I feel. So misconception and challenges. So always the patient's question about the drug and the side effects. Although every system, long-term drugs need specific care, but they may have side effects, but we monitor them regularly and religiously. So it's going to be a short term or a long term. Like if it is reactive arthritis, you get a short term, whereas long term is like rheumatoid or lupus. And steroids and NSAIDs only for a short period. And the Penidur is gone out, and the penicillin also in short supply. Lupus, scleroderma, we always have the challenge of getting them married, pregnancy, and transferring to maternal care. So all of them have implications. We generally talk to the patients and the family members. Biologics, there is a concern that it may cause TB, but in the last 10 years, I have had 2 patients only with the TB, and 1 patient now has developed lymphoma, but we do not know they are linked. So because they have inflammatory disease, which also can cause it. So this was the earlier issues facing us. So there is a delay in diagnosis that is important. That's why this is one of the fora where we can guide the different people. So other specialist opinions we always require in different conditions, and patients' ownership. Like if they are elderly, if they are not able to earn their livelihood, it is difficult. So who looks after? And also in terms of specialty, who looks after? So if it is a renal disease, do they go under the renal, or is they come to rheumatology or come to cardiology? So lots of legal, ethical challenges. As Abulasan was saying, we also have similar challenges. So if you want to follow me, I'm on the research gate, so you can. So been to different countries also presenting our data. We also do Arthritis Day awareness meeting, Osteoporosis Day awareness meeting, and Lupus Day awareness meeting every year in different places. So in summary, there's lots of change scenario in rheumatology diseases. It's not always painful joints, arthritis, steroids, and methotrexate. We have to get to the correct diagnosis. Methotrexate does not help with any of the spinal diseases, and connective tissue disease does not help. So similarly, azathioprine mycophenolate does not help with the arthritis. So they have specific drugs for specific diseases. So diabetes, hypertension is now increasingly being recognized even in the younger age group. So I normally say they are friends. Or sugar vandiruchina, blood pressure கூட்டிட்டு வந்துரும், cholesterol கூட்டிட்டு வந்துரும், இந்த பக்கம் arthritis வந்துரும். So many occasions these 4 are friends. So the fever part I have already explained to you. So lupus is increasingly being recognized, especially after the COVID era. But all lupus can become pregnant. There are only specific contraindications. So I've been to obstetricians forum in different places, even to the national OG conference, trying to explain that a safe pregnancy is always expected in any mother with any connective tissue disease. So patients with polyarthritis, think about infection and also checking inflammatory markers, immune markers before get to the diagnosis. Now, always collaborative approach is the need of the hour, and you can always call when you are in doubt. So with that, I thank you, the academic committee, and also IMA TNSB for giving me this talk. And any questions I can answer at this point. Thank you. Thank you, everyone, and thank you, Chairperson.
Thank you, Dr. Subramanian. Wonderful talk. I'll ask Dr. Srinivasan to coordinate the questions also. That will be much nice. I think the interaction session is going to be very interesting. Srinivas? Srinivas? Aruljothi?
Sir, I will make him, sir. Sir, unga co-host panniteng, sir. You can unmute now, sir. Srinivasan, sir.
Okay, yes.
Yes, sir.
And
Welcome
thank
back.
you, Professor Subramanian, sir, for the excellent lecture. And you scanned through the whole timeline of these autoimmune diseases in such a short span of time. because we know that it is a sea of information is there in the rheumatology. As you said, you can speak about the treatment of rheumatological disease itself for one day. So we know, and you made it so short and practical for all of us, so that we can carry it to a day-to-day practice for the benefit of our patients. Before I open the discussion, I have some few questions from the audience in the chat box. Maybe we can discuss that. Before that, 1 or 2 points I just wanted to suggest to this august audience is always, whenever a patient of connective tissue disease or rheumatoid arthritis, when they come to our OP with other ailments like hypertension, CAD, and so many other things, because they are at liberty to get other diseases also, no? So always look at the prescription of the patient. Whenever the prescriptions, maybe you can see one small dose of diuretic hiding behind a beta blocker. Like that, small things which can matter, and you'll be complaining of toe pain, we'll be prescribing same medicine. You take away the hydrochlorothiazide, maybe the gout will go away. So this type of thing, you have to keep it in mind and look at the patient as a wholesome, especially the drugs which he is taking. You ask him the prescription of the other consultants so that we can give him a comprehensive advice. Another question which commonly most of us usually ask, one thing is whether your pain is worse after getting up from sleep, or is it worse after doing activity? This clinches a diagnosis of inflammatory arthritis, because any pain should be relieved, any normal pain should be relieved after taking rest. Whenever the pain it gets aggravated after when he gets up from sleep, that means there is inflammatory process. All those interleukins, leukotrienes, all the inflammatory mediators get accumulated in the synovium. When the patient gets up, he gets up with a huge, like as if he's getting up with 100 kg of weight. So that is the one thing we have to ask to differentiate from inflammatory from the orthopedic, like musculoskeletal problems. Another thing we maybe worth time spending with the patient is advising the patient educating the patient regarding the medicines which we give. Like sir told during his talk about methotrexate. Just now, yesterday, we had a patient who was taking methotrexate continuously for 4 or 5 days. The patient came with severe glossitis, diarrhea, lady. Unfortunately, she was a 65 years old lady. And when you saw the prescription and we asked her repeatedly, she told methotrexate she is taking daily and folic acid she is taking once a week. So this is a pathetic state of affairs. Sometimes old people who live by themselves, like old couple living in homes like that, they are prone to develop this mistake. And so we have to spend time and educate them regarding the prescription, because it's a very tricky situation. And as sir told, it can be the matter of life and death, because this lady's total count is only 400 yesterday. So we referred to a hematologist, and I think now she's doing well. These are the 3 suggestions I just wanted to make before this August audience. And we'll go to the questions from the audience itself. Actually, one of the questions was, what about the ophthal concerns in rheumatoid arthritis and connective tissue diseases, sir?
Yes, sir.
Professor Subramanian, sir.
Yes, thank you, sir. So just about the methotrexate lady. So generally, my practice is if they are living alone, or if they don't have much understanding about medicines, and if they're elderly, then do not give this methotrexate. Just get safer drugs. That is important. So there are some patients who will have just once in 3 months injection from me, and nothing else, no medicines from me for rheumatoid. So you can modify based on their livelihood and also how they are understanding, how they are living with the tatas and parties. So coming to the ophthalmology, yes. So usually uveitis is more common with the seronegative group, which is like a psoriatic arthritis, ankylosing spondylitis. So painful red eye is common with them. So they get to see the dermatologist, ophthalmologist first, and then get referred. Or even old patients, if they have eye problems, we are sensitizing them to get to the eye team sooner. So we have 3 different eye hospitals here, so they are all well aware. They quickly refer the same day review by them and by me. With regards to rheumatoid, you get scleritis, and also you get scleromalacia perforans, which is like in a bad outcome. Eye is, we are going to lose the eye kind of. So that is also there. But nowadays, with most of our rheumatologists are trained to look at the complications and also the disease being modified very well. So you see less common these things. Occasionally, who cannot access the medical care. There are some villages who don't have like a borderline in Kerala and here, and somebody from nearby Munnar, they only have these problems with the scleritis and perforans, but otherwise less common. So the third point is hydroxychloroquine can cause pigmented retinopathy, but that is only if you are using twice daily dose for longer than 3 to 5 years. So we do not use them longer and keep it as a 6 milligram per kilogram dose. So apart from that, retinal vasculitis, especially in patients with the systemic vasculitis or a charcot, they also can manifest with eye involvement. So these are common, and there are other diseases also with eye involvement.
Sir, ESR versus CRP, sir. What is the disease? How will you predict the disease activity of this?
So in those days, anybody who have painful joints and high ESR, think about rheumatology. So ESR was the earliest biomarker for referral to rheumatology. But then ESR just shows that we have high antibodies or high globulins. That's it. So it may be cancer, it may be TB, it may be inflammation. So ESR is for a longer term, whereas CRP is acute. And all of our inflammatory diseases except lupus will have both ESR and CRP raised. But usually ESR will be around 60s and 70s and CRP is 20s and 40s. If somebody who has more than 100 ESR, then think about malignancy, like myeloma, lymphoma, so or HIV. So all those things have to be remembered if ESR is very high. And CRP more than 100, you can get an acute gout or you can get in sepsis. So rheumatologic diagnosis, less than 100, both of them. But both are abnormal except in lupus, when you have only ESR is high, CRP is normal. But having said that, those who are getting admitted, they are admitted either because of infection due to cytopenia, neutropenia, or they may have vasculitis. So that again pushes the CRP up. So it's old age teaching that both will be up and not in lupus. But nowadays we tend to see both are high in all rheumatologic diseases. But CRP is the acute marker. ESR is a chronic marker. ESR will not become normal, whereas CRP can be normal with your treatment.
Okay, thank you. So what about the genetic connection and rheumatoid arthritis? Suppose the son asks, the daughter asks whether I may get it from my mother, what to do? What to tell, sir?
It is there, sir. So, yes, definitely. So, முதல்ல வந்து கேட்கிறது patients ask, have I inherited from my parents? It is possible, but we do not know about your parents. Can you pass on to your children? Yes, it is possible. So, unless we find the genetic marker for this patient, we can't really say. As of now, HLA-DR4 is the only genetic link proven. There are other HLAs also, but then they are not fully 100% proven. So, if a mother has rheumatoid and found to have HLA-DR4, then 1 in 3 child can become positive for rheumatoid. So that's a genetic link. That is about the rheumatoid. HLA-B27 is another one, which is predominantly in boys and found to be in patients with ankylosing spondylitis. But there, 10% of population can have HLA-B27 without any disease. So those who have a disease in their parents, so only 2 to 3% of younger ones, children, can have B27 positive. So, less common. Okay. But there are patients who children have been under my care, and then after 5 years or 6 years, their parents are now coming, sir, enakkum back pain irukku. They now have the disease. Although they carried the gene for so many years, they didn't have any manifestation until now. So that also is happening.
Okay, thank you. Another question from the audience is about the pediatric patients. What is the perspective from your side, sir? Like Still's disease and so on. I don't know.
Yes, it's juvenile arthritis is more common. Next is Henoch-Schönlein purpura is more common, and then ITP, and less common with lupus and Still's disease is very less common, sir. So somebody who has arthritis with high fever and also high ferritin and multi-organ involvement is Still's disease. So it's acutely high risk, but once you treat them well, and they do not recur. So recurrent Still's is not a case at all. Very good response to treatment. IL-6 blocker give like Actemra is the drug which is to be given for patients with COVID. It is very good for Still's disease too. So that is about Still's disease. But pediatrics, I think After the COVID era, we are seeing more number of patients with immune system disease, even in younger population. So we do have systemic vasculitis, even younger patients with Takayasu vasculitis. All are increasingly being recognized. Maybe because of the diagnostic tool we have, but they also come with the different symptoms too. But in pediatrics, anybody with this multi-system joint disease always think first whether it's leukemia, because very closely mimic as lymphoma, leukemia, mimic as inflammatory arthritis. So, many occasions we do a bone marrow study before we jump on immune modification drugs.
Okay.
Thank
you. Okay. What about the use of this? Another question. What about the use of the biologicals in our day-to-day practice, like general practitioners and other things? Is it really a harmful weapon, or what is your opinion, sir?
It's yes, it's a harmful weapon, sir. So reason being, because our country is more epidemic with tuberculosis, and these biologics knock the cytokines off. And if, for instance, if I am taking methotrexate, I'll become pancytopenic within 2-3 days, because there is state for the drug to work. So they develop side effects. Same way, all these biologics, any drug, but biologics, they have potentiality to knock the immune system off. So whichever cytokine it is blocking, it is blocked. So it is difficult to come out of it. So for instance, fever, you get IL-1 inhibitor, which is the specific fever, TNF-alpha and IL-1. So you knock the fever off, but then the fever is an inflammatory response to any bug. So we are stopping them. So infections do not use any of these. Inflammation, if we confirm that it is inflammatory, usually oral DMARDs are safer, because as you said, the 65 vayas lady had taken multiple doses of methotrexate. So even this one, it can cause. So in future, we may get more tuberculosis if you're using biologics as a primary drug. So usually it is reserved for patients who are resistant to these standard drugs or not responding to standard drugs, then we can consider. You can always have a collaborative approach, sir. So you can discuss with the nearby rheumatologist and get the treatment to the patient.
What about the management of this rheumatological disease during pregnancy, sir? Just
Yes,
give
sir.
a few points. I know it's a wide topic. Can you give a
Correct.
few practical suggestions for our lady doctors also?
Okay, sir. So if somebody who has any rheumatological disease before pregnancy, so we counsel them even before getting married. And 3 months before we stop the offending drugs or risk drugs, and then change to safer drugs. So mycophenolate, methotrexate, leflunomide, no at all for any of these patients. So they all will be stopped 3 months before planning pregnancy. Sulfasalazine, hydroxychloroquine, azathioprine, tacrolimus, these are all safe drugs. So we transfer them to the safer drugs before 3 months before pregnancy. And usually, for instance, lupus, we look at biomarkers, immunological like complements also prior to pregnancy. And we normally collaborate with the obstetrician all along during the pregnancy, delivery, breastfeeding. So usually many of the rheumatic diseases can be safer during the pregnancy, but can get worse in the postpartum period because of the hormones in an imbalance. You get more progesterone, now you get more estrogen after delivery. So lupus can become worse during the pregnancy itself, but we always collaborate and we manage then and there quickly before they get systemic complications. So that is about the drugs, but it is a safer pregnancy. So, and if they have APLA, then they will be on heparin all along the pregnancy until the delivery, and then move on to aspirin or warfarin, depending on the condition. If it is definite APLA and thrombosis, they will be on warfarin. But if it is just miscarriage and APLA, then you get aspirin enough. And some cases, we tend to give heparin even 6 weeks postpartum, because the risk of postpartum cortical vein thrombosis is high in patients with APLA syndrome. So that's about pregnancy in a nutshell, sir.
Okay, sir. Nice. Thank you, sir. Another thing is the gold standard drug for ankylosing spondylitis. Is there any drug like that?
If it is ankylosing spondylitis, as I said before, it's a spectrum of 5 diseases: uveitis, colitis, psoriasis, Achilles tendonitis, and also spondylitis. So the drug being chosen is based on which system is getting involved. And if it is predominantly only spinal, only biologics will help. Because sulfasalazine has been still used, but it is only for peripheral joint involvement. It doesn't do anything with the spinal disease. So we may very well give with the anti-inflammatory drugs like naproxen or indomethacin for the spinal disease, which has a better outcome than sulfasalazine. Because sulfasalazine in a boy, generally risk of oligospermia, azoospermia is also there, and it may not have anything for the spine. But having said that, so it may have a beneficial impact on prevention of colitis and also peripheral arthritis. So people are using sulfasalazine for spinal disease based on these 2 factors only. So gold standard drug is biologics for spinal disease.
So another question is when to suspect a sarcoid when the patient comes with this type of arthritic symptoms?
Yes, sir. So sarcoid, you get usually fever. It's like TB. So whatever symptom you get for TB, you get for this: fever, weight loss, cough, breathlessness, lymphadenopathy. All of them may be there. And some people may have joint disease, and some people may have skin disease, which I said sarcoid. So especially in the shin, so you specifically need to look for it. So, and some people have sarcoid eye disease, sarcoid neurological complications, and sarcoid renal disease. So they are also less common. So it's like TB, but then only the biopsy will give us. So patients may have high CRP, high serum ACE level, which is an angiotensin converting enzyme, because it's from the lung. So it's a high in these patients, especially pulmonary sarcoid. And you have a biopsy which showed non-caseating granuloma. So that is again sarcoid. Whereas caseating granuloma is TB. That way we diagnose it, sir.
So maybe the last 2 questions, sir. One is any role for PET-CT in Takayasu arthritis?
Definitely, sir. So for Takayasu confirmation, so normally you do a pulse assessment and then echo, and then you do a CT angiogram to look at which vessels are obstructed. So that's about the extent of the lesion. So we are trying to find out, is it aortic arch disease? Is it thoracic aorta? Is it abdominal aorta? Renal vessels, celiac vessels. Once you've done that, you're getting treatment. So if there is occlusion totally, then you get bypass or stent, whichever is required based on the condition. And once you are on treatment, the PET-CT will tell you whether the treatment has worked, whether it's still activity, whether we have to modify the immune drugs. So PET-CT is looking for the activity. So அது வந்து இந்த அல்ட்ராசவுண்ட்ல பார்க்குறோம்ல the vascular enhancement. Similarly, you get in PET-CT for patients with systemic vasculitis, but it's a separate protocol. நம்ம நார்மலா PET-CT வந்து metastasis தான் பார்க்குறோம் as of today. But அந்த protocol கிடையாது, vasculitis is a different protocol. So we have to specifically mention that it is vasculitis protocol. They will do that. We have done that, sir. Some people may have myocardial disease. Some people have still active disease in the cerebrum, which இப்போ வந்து stenosis இருக்கா இல்லையான்னு சொல்லும் MR or CT angiogram. But active இல்லையாங்கிறது PET-CT will tell us. So we have used that in specific occasions. Good question, sir.
Prognostic, it is a follow-up, it is useful, I think. That's what you say, sir. Follow-up of treatment.
Yes.
So this presentation of this polyarthritis and muscle pain, other thing, when will you suspect a paraneoplastic manifestation? You consider this as a paraneoplastic when you suspect maybe a lung cancer or something like that.
Yes, sir. So polymyalgia rheumatica is a condition where you get aches and pains predominantly on the shoulder and the hip girdle, and usually it's 55 and above. So we do not diagnose it in 30s and 40s. So that is not the diagnosis. And if they have a headache along with it, think systemic vasculitis, giant cell arthritis. There is a standard rheumatology diagnosis. So suspecting malignancy, as I said, in a children with the high fever and weight loss, we tend to think about lymphoma, leukemia, and myositis. Think about dermatomyositis, polymyositis may be associated with the especially ovarian and lung malignancy. So think about that. Or if we have fibromyalgia rheumatica, usually patients have only the hip and the shoulder involvement PMR. But if they have like a digits involvement, finger and toe involvement, it may be parablast. Especially in lung cancer, you get arthropathy in the wrist. So that is that may manifest along with the PMR. So PMR, except hip and shoulder, predominant peripheral arthritis, think about malignancy. Of course, like lung disease, bowel disease, you may have specific symptoms. So especially bowel disease, alternating diarrhea and constipation, which is a feature of colonic malignancy. And a chronic anemia undiagnosed is ascending colon malignancy. So that is we all tuned to pick up that in early on. So many occasions it's true. Once we put down the scope, we get that diagnosis. Hopefully that answers that.
Ashraf sir.
Thank you, and Dr.
Also.
Over to Dr. Ashraf sir and Dr. Aruljothi sir.
Is Sridhar online? Sridhar could not come online.
Sir, he is not
Very
able
useful
to
presentation. I think a lot of our delegates will benefit. Okay then. You conclude pannunga if Dr. No more questions.
I think we have answered most of the questions from the audience, sir. I think Dr. Ashraf sir can take over.
Okay.
Thank you, Dr. Subramanian. I think it is a useful topic. I think I would request you to give us a copy of the article so that we can print it in a book. We wanted to bring them. Ultimately, we want to compile all the lectures in the last 10, 11 months, make a contribution probably in January or February, so that all our people who are, we can send a copy of the book to them. It will be sincere about it. It will be good if it is in the form of a book. Dr. Srinivasan can give a brief summary or a preamble, and then Dr. Subramanian topic. Okay, Subramanian, thank you very much.
Yes, sir, definitely.
Yes.
It's a phenomenal work.
Come on, Aruljothi.
So,
Yes, sir. Yes, sir.
Dr. Ablasan, is he online?
Sir, Illing, sir. Sir.
So I must thank Ashraf sir, Dr. Aruljothi, Dr. Srinivas sir, and also the TNSB for giving me this forum. So I'm also like complete tenure in the Tirunelveli branch. Thank you once again.
Thank you so much. Thank you.
Thank you, sir. Thank you very much,
Thank you,
sir. Sir, till November,
just thank the audience, delegates.
Yes, sir. On behalf of IMA TNSB Academic Committee, we thank all the speaker, moderator, as well as all the participants. Thank you very much for your active participation, because we received more than 25 questions through Google link in advance. It helped us to moderate the session smoothly. Thank you very much. Please do type your details, name, TNMC number, email ID, and phone number in the chat box. It will help us to process your TNMC credit points. Thank you very much. With this CME, we completed 10 TNMC, 10 CME programs, sir. Thank you, sir. Thank you very much, sir.
Thank you.
Aruljothi made things easy for me. You did a stupendous task, and let's continue this work in future also. Thank you, Srinivas. Thank you, Subramanian, Aruljothi.
Thank you.
All our office bearers, state office.
Thank you.
Delegates who participated.
Have a good evening, sir. Thank you.
Thank you.
Good evening. Have a nice day. God bless all of you. Thank you so much.
Thank you, sir.
Dr. Aruljothi, quick question.
Yes, sir. Please, sir.
Have sent a PPT. Is that enough, or you wanted something like a bullet points, 10 points?
Sir, we want write up for printout publication, sir.
Is that how many words? Something limit?
No limitation, sir. You can give 2-3 page also, sir.
Okay, sorry.
Yes, sir.
Thank you.
Yes.
Give me a few days. Is there a
Yes.
deadline?
No, sir. No, sir. Within a week, if you give, it will be helpful for us, sir.
Okay.
Thank you, sir. Thank you, sir. Thank you.
Thank you.